Good morning, everybody. I'm Howard Jansky. I'm the chair of the Department of Orthopaedics and Sports Medicine at the University of Washington. Welcome to our first grand rounds of the new 2022 academic year. Welcome to all of our new interns. Today, we're fortunate to have Kurtis Carlock, who is a new R4 orthopedic resident, as well as Dr. Navin Fernando, who is an associate professor, as you all know, in our department. And then Dr. William Ehni, who's a clinical assistant professor in the Division of Infectious Diseases for the Department of Medicine, to discuss medical and surgical management of prosthetic joint infection, current evidence and controversies, something that none of us enjoy seeing, and we are fortunate to have a great team of support from our Division of Infectious Disease, and I'm grateful that Dr. Ehni was willing to come and lend us some of his expertise this morning. And with that, I'll introduce Dr. Carlock to begin grand rounds.
Great, thank you so much, Dr. Jansky. So for anyone who may not know me, my name is Kurtis Carlock. I'm a current R4 here in the Department of Orthopaedic Surgery. I'm joined this morning by Dr. Ehni from the Department of Infectious Disease and by Dr. Fernando, also from our Department of Orthopaedic Surgery. We'll be discussing the medical and surgical management of prosthetic joint infection with an emphasis on current evidence and controversies. We do not have any disclosures. To provide a quick overview of the topics that we'll be discussing today, I'll begin with a quick review of the epidemiology of prosthetic joint infection, quickly discuss the various types of prosthetic joint infection, and then I'll be really focusing on the techniques that we use to diagnose patients with prosthetic joint infection, reviewing the evolution of our diagnostic criteria for PJI over time, and then really focusing on our future directions in diagnosis, specifically the relatively new tools and future developing tools that we see kind of in the pipeline. Dr. Fernando will be focusing on the surgical management of PJI, while Dr. Ehni will be discussing the medical management. So as we all are familiar, the incidence of primary total hip and knee arthroplasty has been steadily increasing year over year in the United States. This increase in primary arthroplasty procedures has been accompanied by a concomitant rise in revision arthroplasty procedures. And amongst those patients who are undergoing revision arthroplasty, prosthetic joint infection is quite a common cause. PJI is the most common cause of revision for failed total knee arthroplasty and the second most common cause of revision for failed total hip arthroplasty. But amongst these patients who are presenting with PJI, we really are dealing with two very distinct cohorts. Those two overarching cohorts are those patients presenting with an acute infection versus those presenting with a more chronic infection. Now, typically we're thinking of these patients with a chronic infection as those who have a more difficult to arrive at underlying diagnosis. These are the patients who may be coming in with sometimes years of symptoms. They may have undergone various previous forms of treatment, whether that be previous antibiotic therapy, previous surgical intervention, and oftentimes these are the patients who were having a very difficult time diagnosing. This is in contrast to patients coming in with more acute type infections, where in the majority of cases, we think of the clinical picture as being more cut and dry. Of course, that is a simplification. There are patients with more unclear acute infections as well. And then within that group of patients who are coming in with acute infections, we're dealing with two subcohorts as well. We have our patients with our acute post-surgical infections, which are those that are occurring less than 3 months from our index arthroplasty procedure, and those coming in with acute hematogenous infections, which are those that are occurring farther out from the index operation but have been symptomatic for a relatively shorter period of time, often with a presumed primary etiology of their infection, whether that be a distant soft tissue infection or any other variety of potential sources. So As I was mentioning, the patients with chronic infection are those that are typically quite difficult to diagnose. And to kind of address the difficulty that we're facing, or that we were facing in determining which patients truly are infected and those who are not, the first widely accepted set of diagnostic criteria for PJI was developed back in 2011 by the Musculoskeletal Infection Society. I know many of us are going to be familiar with these overarching criteria, but to provide a quick review, the initial set of diagnostic criteria involved major and minor criteria, where any patient who met any one of the major criteria was considered infected, and any patient who met any 4 of the 6 minor criteria was considered infected. This initial tool was quite crude. It did not have any cutoffs on a quantitative front for the minor criteria to differentiate between those patients with acute versus chronic infection. And as we'll see, the degree of those markers can be quite different in those 2 populations. And it did have, or it did incorporate some factors that would come to be considered a little more crude, a little more imperfect of infectious markers, specifically the presence of purulence in the joint. So to address these shortcomings, this initial diagnostic tool underwent some modification or an update in 2013 with the release of the modified MSIS criteria. So these updated criteria tried to address these shortcomings of the first iteration of the diagnostic tool through a couple means. First was trying to differentiate between those patients with acute versus chronic infection and introducing diagnostic quantitative cutoffs for each of the minor criteria between those 2, and removing some of what we at the time considered more crude tools, specifically the presence of purulence within the joint. So these 2013 criteria were the first that became really widely universally accepted. They became very popular for use in both a clinical setting and in the research setting. Still to this day, the 2013 criteria are often used in terms of the tool that's used to confirm or diagnose infection in the setting of research. But this tool still does remain imperfect. So since 2013, numerous new diagnostic tools have been developed. Much new research came out kind of validating new tools, casting doubt on certain old tools, and kind of refining the way that we use those. So to address those new findings over the course of time, the most recent iteration of the diagnostic criteria was released back in 2018, which really presented a much more evolved, much more refined take on the way that we approach the diagnosis of prosthetic joint infection. So it continues to incorporate both major and minor criteria to try to arrive at the ultimate diagnosis. But where this most recent iteration of the diagnostic tool really gets refined is the way that they approach the diagnostic criteria, or the minor criteria, I should say. They try to divide things into a set of preoperative tools, incorporating both serum and synovial markers that can be used to try to arrive at an ultimate diagnosis. And only if those preoperative tools are not diagnostic do we move on to incorporating some intraoperative markers to try to arrive at an ultimate diagnosis. But one point where I think that the most recent set of diagnostic criteria is very effective and very unique is I draw your attention in the bottom right chart here, demonstrating that the authors did incorporate in the fact that even this iteration of the diagnostic tool, while it was the most up to date, is not perfect. They did leave room for there to be inconclusive results, accepting the fact that PJI can be a very difficult diagnosis. It may not always be clear. And even though this is the most updated or most recent iteration of a diagnostic tool, there are some patients who we still may not be able to arrive at a definitive diagnosis. So valuable there. They did include the same quantitative cutoffs as the earlier 2013 criteria, but it is important to mention that this system does remain imperfect. I think the most important thing to remember when we're dealing with any of these diagnostic tools for PJI, whether they be these overarching criteria or individual tools themselves, is we do not have a true gold standard tool for PJI diagnosis against which we can compare. So in these patients who may have more indolent, difficult to diagnose infections, ultimately, we may actually never know if they truly were infected. So when we are trying to validate these tools, where we often end up comparing them in some ways to themselves. If the 2013 criteria were the best tool that we had at the time, in the ultimate development of the 2018 criteria, in some ways we were comparing the 2018 criteria to the 2013 criteria when trying to determine sensitivity and specificity. Certainly a limited approach, certainly an imperfect system, and as things continue to develop, new tools are developed, it continues to refine the way that we are applying that system. And then sometimes there are some factors outside of our control in terms of how effective these diagnostic criteria are. One thing that comes to mind early for many of us is that not all patients are created equal. Some may have received antibiotics, which can affect the quantitative values of many of these diagnostic markers, oftentimes diminishing their diagnostic utility. And certain patients, depending on the virulent bacteria or the type of bacteria or pathogen that's causing their infection, can ultimately make our ability to use some of our diagnostic tests more difficult. For example, shown in this recent study out of JOA, they found that patients with more indolent, less aggressive bacteria may require relatively large volumes of joint aspiration in order to get an adequate sample to perform some of our tests, specifically cultures. So if we're not able to get an adequate volume of fluid, maybe the results that we're getting are not useful in and of themselves. So certainly multiple factors affecting our ability to utilize these criteria, something we need to keep in mind when we're dealing with some of these patients with more difficult to diagnose infections. So moving on to discuss some of the newer diagnostic tests, trying to emphasize those that have begun to be incorporated into our diagnostic criteria. The first one I want to discuss is D-dimer. D-dimer is going to be unique from the other new tests that I'll mention, in that D-dimer itself is a serum marker. There's kind of been a big push or a renaissance in terms of the diagnostic tools available to us, in that they've really been focusing on the on synovial markers as the new tool, given that that wasn't something, wasn't an area that we were emphasizing much prior to 2010 or so. So D-dimer is one that's come out relatively recently as a tool that we can test preoperatively without any kind of invasive arthrocentesis or other procedure. So D-dimer itself is kind of a marker of fibrinolytic activity, with fibrinolytic activity being elevated in settings of local and systemic infections. So given that D-dimer itself was recognized as representing an acute phase reactance of sorts, it was first examined as a marker for prosthetic joint infection back in 2017. Initial results were really quite promising, with a sensitivity and specificity of around 90% on early studies. Given these promising results, it actually was incorporated into the 2018 diagnostic criteria as a potential very useful tool. More recent work, however, has begun to cast some doubt on how reliable of a marker D-dimer truly is. Specifically, some of our pathology colleagues examined the variability that we're seeing in our laboratory examination of serum tests, seeing quite a significant bit of variability, kind of casting some doubt on specifically the quantitative cutoffs that we're using. Maybe in and of itself, it is a valuable marker, but perhaps we need to revisit the quantitative cutoffs that we're using. And then as more better designed prospective studies have begun to come out, they've kind of begun to cast some doubt on its utility as a diagnostic marker in patients with more slow, indolent, less aggressive type infections. So now moving on to some of the newer synovial tests. So synovial tests, as I mentioned, is where we've really seen a renaissance or a growth and development of a significant number of new tools. So the first of those that I'll mention is leukocyte esterase. So leukocyte esterase is something that we're likely all familiar with, as recognizing it as one of the markers that we're looking at in the setting of urinalyses, looking for potential urinary tract infections. So as with a urine sample, a synovial fluid sample can be placed onto a colorimetric strip test, and the degree of color change that we see indicates the degree of positivity, with it being a truly qualitative test, not quite a binary yes or no, positive negative test, but really degrees of positivity depending on the or the degree of color change. This really qualitative nature, non-binary nature of the study does provide some limitations. specifically when, at what time point do we want to look at our test to determine the results. This was cast into doubt in this recent 2021 study in core out of China that noted that although the manufacturer of these colorimetric strips was recommending examining the test at 3 minutes, actually the best diagnostic accuracy they found to be at 5 minutes. So certainly it is evolving on that front. And then, as I was mentioning, since we don't really have a true binary cutoff, positive, negative, rather there's various degrees of positivity, it still is yet to be determined which one of those degrees of positivity has the greatest utility in terms of diagnosing these patients. Variable sensitivity and specificity across those, something to be refined as we move forward. So next, moving on to alpha defensin as our next new diagnostic tool. Alpha defensin is likely the new synovial marker that's been greeted with the most enthusiasm, has been viewed as being the most promising. Alpha defensin itself is an antimicrobial peptide that's released by neutrophils in the presence of pathogens. It was initially studied as a PJI marker back in 2014 and has had very promising results. This table here out of a recent meta-analysis of prospective studies examined the utility of various synovial markers and found that alpha defensin overall was found to have a sensitivity of 97% and a specificity of 96%. So a very, very promising results, very promising marker. And furthermore, alpha defensin was found to be very useful in patients on antibiotics, which is unique in that it retains its diagnostic ability in these patients. As I had been mentioning earlier, the use of antibiotics often clouds our ability to interpret our test results in various serum and synovial markers, but alpha defensin is unique in that it does not have that shortcoming. Its diagnostic ability is retained in these patients. And then given the promising initial results that were seen with alpha defensin, it was initially developed as more of a standard laboratory test where a synovial sample is sent off to a lab. We wait 24 hours or so to get our results back. But given how strong or how promising our initial results were, a qualitative kind of rapid type lateral flow test was developed for use at the bedside or potentially for use at the bedside, even potentially being able to be used in clinic or in the operating room. It functions quite similarly to other more rapid type tests that we're familiar with, like a rapid COVID test or a pregnancy test where a sample is placed and we get a binary positive or negative result. Initially, there was some doubt regarding the effectiveness of this qualitative version of the test, but the qualitative version has been studied extensively compared to the quantitative version, and overall the sensitivity and specificity between the two have been found to be largely equivalent. So for now, the results are quite promising for alpha defensin. It's been incorporated into the 2018 criteria with either the quantitative or qualitative flow being a viable option. And then the last new synovial marker that I mentioned is Synovial Calprotectin. This is a relatively newly developed diagnostic tool, relatively poorly studied to date. Calprotectin itself is another protein that's released by activated neutrophils. Really starting to see a trend there. The initial idea to begin examining it as a possible marker for PJI stemmed from its established use within the GI literature as a marker for inflammatory bowel disease. So given its established use as a potential marker, it was proposed as a PJI diagnostic tool in 2017, and this so far had some promising results. There really hasn't been much published looking at it, but so far our initial results have been quite promising with very favorable sensitivity and specificity results so far, but still early. This will be a tool to continue to watch moving forward. And then the last overall diagnostic tool I want to discuss is the use of next generation sequencing. So next generation sequencing is often used in patients who we either A, want to confirm truly have an underlying infection, or B, patients who we have diagnosed with an infection, we truly believe are infected, but have been unable to identify the source bacteria that's causing their underlying infection. So next generation sequencing, a sample is sent off to a lab, PCR amplification of bacterial DNA is used. Samples are cross-matched with a database of over 25,000 bacterial species to determine if there are any bacterial samples or bacteria present in that sample. Some criticisms of this technique have been that it's maybe overly sensitive. It's often led to the identification of different and unusual organisms, with microbes being identified in about a quarter of aseptic revisions and over a third of primary arthroplasty patients. So these positive results have begun to raise some questions of are these bacteria that we're identifying with next generation sequencing truly representing an infectious pathogen, or are we identifying bacteria that may have been a contaminant, or perhaps are we even beginning to see signs of a intra-articular microbiome that we're just now beginning to learn about? So interesting area of research. And in terms of its utility in diagnosing PJI, about 2/3 of patients with culture negative prosthetic joint infection have been able to have potential pathogens identified by next-gen sequencing, which certainly does provide some help to our infectious disease colleagues as they attempt to tailor antibiotic therapy. So in summary, regarding diagnosis, prosthetic joint infection is sometimes a very easy diagnosis to make, but oftentimes it's very difficult. This difficulty in making a diagnosis is complicated by the fact that we have yet to develop a true gold standard test for the diagnosis of PJI. Currently, our 2018 criteria are a leading diagnostic tool, but we will undoubtedly continue to see our approach to diagnosis evolve over time as new tests are developed, as we continue to refine the current tests that we're already using. And so on that, I'll hand things off to Dr. Fernando.
All right, can you guys, can you see that okay?
Looks good.
Good, great. All right, so thanks, Kurtis. That was an excellent overview of some of the advances that we've made, and certainly some of the future directions that we can anticipate in the diagnosis of PJI. So obviously we made tremendous progress, and testing that is available can provide very accurate information as to when there is an infection. The difficulty in many respects is everything that occurs after the fact. So the surgical treatment of PJI after total hip and knee arthroplasty remains extremely controversial. Each of the outlined topics below could likely fill several hours. So my objective today is to provide the most salient research that is currently driving practice and to focus on topics specifically which pertain to total joint arthroplasty and antibiotic management, as well as to provide my approach to treatment with some case examples. And interestingly, although I know Dr. Ehni has partners, every case that I'll be discussing today, perhaps coincidentally, has involved his co-management. So to briefly review and reemphasize why this is such an important question. So number one, incidence of PJI is increasing concurrently with an algorithmic rise in total joint arthroplasty. The number of primary and revision total joints being performed are anticipated to increase exponentially, as Kurtis mentioned, and the most common cause for revision is quickly becoming infection rather than aseptic loosening. Bacterial epidemiology is changing with more virulent organisms such as MRSA, fungal and polymicrobial infections, which have complicated our treatment options. Demographics and indications for total joint arthroplasty are also changing. Patients are not becoming healthier, generally speaking, and although they may live longer. Although risk factors for infection have been extensively researched, the list is certainly non-inclusive, and many of these are unfortunately non-modifiable. The impact of PJI on morbidity and mortality is obviously also quite significant. So what is the current evidence for antibiotics in the prevention of PJI in primary total joint arthroplasty? So a fairly unusual and somewhat convoluted evolution has occurred, particularly over the last 15 years. In 2006, the CDC and SCIP guidelines concurrently recommended a preoperative dose of antibiotics prior to incision specific to the procedure, in addition to 24 hours of continued antibiotics. This strategy continued without controversy for the next decade or so. In 2017, however, the WHO and CDC revised their guidelines to recommend against the use of any postoperative antibiotic, citing absent evidence in clean elective surgery. The recommendation emphasized the fear of bacterial resistance and concerns of side effects of prolonged unnecessary use. This decision was met with significant concern, however, from the orthopedic community, with criticisms made that largely non-arthroplastic literature was used to make this recommendation. And as such, in 2018, the ICM defined this recommendation and suggested continued antibiotics in the postoperative period until adequately powered studies were performed demonstrating safety. So in full orthopedic fashion, not only have the CDC guidelines been ignored, but full momentum and interest has developed in the role of prolonged antibiotics beyond the 24-hour period in higher risk patients. So this group from Indiana first published their 90-day outcomes in JBJS in 2018 and updated their findings in 2021 with 1-year follow-up suggesting a reduced risk of infection in their high-risk treatment population. So how do they define high risk? So this is a busy slide because it was a very broad characterization. It included risk factors such as BMI over 35, diabetes, or any autoimmune disorder. So ultimately, high-risk patients received 7 days of cepodoxil or Bactrim for MRSA, clindamycin if they had an allergy. In comparison to those patients who did not receive the protocol, and even in comparison to those patients who were considered low risk, the rate of infection in those patients who received the prolonged antibiotic treatment were lower statistically. So certainly the study has some flaws, and I suspect the population in Indiana must be fairly close to ours, in that after their protocol was implemented, it appears that approximately 70% of their patients were discharged on this antibiotic extended course. So as much as I despise PJI, it doesn't strike me as pragmatic or particularly good antibiotic stewardship. I'm operating after grand rounds today, and I can tell you I'd be batting 5 out of 5 based on this protocol. So although we have no formalized protocol at UW currently, personally I have not implemented this strategy in my patients, although I do consider it more selectively. Currently I've begun to implement this regimen in high-risk revisions and conversions, and in our highest risk patients, such as those with HIV, chronic lymphedema, post-transplant, or a history of septic arthritis. So this is an example of someone who I think may benefit from extended antibiotics and was discharged in 7 days of prophylactic cepodoxil. This is a 32-year-old woman, 5'5", 350 pounds with a BMI of 58, who sustained a non-traumatic displaced femoral neck fracture, previous medical history relevant for PTSD, schizoaffective disorder, chronic pain syndrome, and intertrigo. She underwent open reduction internal fixation in August 2020 at Harborview. Ultimately, she unfortunately went on to non-union, a fracture of her hardware identified at 6 months follow-up. This was thought to be an aseptic non-union, but certainly she has risk factors for underlying infection, and this is not always a diagnosis that can be accurately made. Regardless, given her degree of disability and the low likelihood of optimization in a reasonable time frame, she was offered and underwent total hip conversion. She was doing well at 6-week follow-up, but hasn't been seen at her 1-year follow-up, so hopefully not someone that'll be lost indefinitely. So what about DARE, or debridement, antibiotic, and implant retention, formerly known as IND and poly exchange, and the role of prolonged antibiotics? So there's a whole other controversy as to who is an appropriate candidate for this procedure as opposed to revision arthroplasty. The ICM group suggested patients with acute postoperative infections and acute hematologous infections with symptoms less than 4 weeks were reasonable candidates. So the success rates in the literature, however, have ranged between 20 and 90%. So why not attempt to DARE, even though success rates vary widely, given that the morbidity is relatively low in comparison to any revision arthroplasty? The question and concern is consequence. So namely, does doing so affect the subsequent ability to eradicate infection through a two-stage exchange should infection persist or recur? So the ICM's official position on this is unknown based on available data. This opinion has been predominantly shaped by 2 papers in the literature documenting contrasting outcomes. So this study from 2010 by Sherrill et al. Was a multi-centered retrospective review of 83 patients, suggesting that previous IND affected the possibility of achieving success with a subsequent two-stage exchange, with a 35% failure rate reported. This more recent study, however, from the Cleveland Clinic group in 2016, suggested that previous IND had no effect on long-term outcome, and as such was defensible. And in fact, those patients with an IND had a non-statistical but approximately 2-fold reduction in persistent infection in comparison to those who did not. So again, assuming that DARE is controversial but appropriate in certain circumstances, is there anything we can do post-surgically to reduce the risk of recurrent infection? Namely, in this case, the duration of post-operative antibiotics. The ICM again reviewed the literature, suggesting the answer is unknown, although it appears that 6 weeks of antibiotics post-DARE is sufficient in most cases. This paper, published in JBJS in 2015, also out of the Cleveland Clinic, likely has had the largest influence in proponents of prolonged antibiotics post-DARE. 92 patients received a minimum of 6 months of antibiotics in comparison to a matched cohort after diagnosis of an acute or chronic PJI. Patients either underwent DARE or a two-stage exchange. The 5-year infection-free prosthetic survival rate was roughly 70% for the antibiotic suppression group and only 40% approximately for the non-suppression group. And those patients who had a DARE or had an MSSA infection have the greatest benefit. So this is a recent case of an 80-year-old retired astrophysicist and inventor, 3-month status post-index primary total knee arthroplasty who had no perioperative complications and was progressively and doing well. He presented with approximately 4 weeks of progressive pain, bacteremia on admission, and purulent drainage from incision. Multiple medical comorbidities, inflammatory markers, and aspiration definitive for an MSSA periprosthetic joint infection. So a lot of conversation was had amongst the joints partners regarding best treatment for him, with some disagreement. But my feeling, based on the morbidity involved in resection, the patient's surgical risk, as well as timing from the index procedure, that an attempt at least at DARE was reasonable. So he did undergo an IND and Paul exchange, and the plan is for Cevilex and QID for 6 months. Currently, his CRP is normalized and his ESR is improving, approximately now 5 months post-op with minimal pain, full range of motion. So obviously this still represents short-term follow-up. So are there circumstances where DARE and prolonged antibiotics are preferable in comparison to a two-stage exchange, even in the context of a chronic infection? So this wasn't a question directly addressed by the ICM, interestingly, but regardless, there really wasn't significant evidence available to direct treatment. This paper, however, from JBGS in 2021 from the Ortho Carolina group looked at DARE and antibiotics versus a two-stage exchange for patients with extensive instrumentation in PJI, meaning in this context, porous metal sleeves, cones, or long stems. Their patient population consisted of 87 patients with PJI and extensive instrumentation status post-total knee revision. 56 patients were treated with IND, 31 patients with a two-stage exchange. There was roughly a 62% infection-free rate in the IND group and a 67% infection rate for the two-stage exchange. So effectively similar rates of infection and a minimum 2-year follow-up. So interestingly, and also concurrently, only 58% of patients actually underwent reimplantation. So taking that into account, only roughly 40% of patients successfully underwent both a reimplantation and were infection-free. Equally concerning, the mortality for both groups was approximately 40% at latest follow-up, which is also consistent with similar studies in the literature. So this is a 68-year-old gentleman, a Ukrainian immigrant, who presented to my clinic post-septic hip ankylosis with dissolution of his femoral head in acetabulum, which had been treated non-operatively. So he was told that he was too sick for surgery and was treated with antibiotics only. If you've learned nothing else from recent history, it's that Ukrainian people are fairly resilient. So not surprisingly, he survived. He emigrated to the United States and presented with this problem. His preoperative aspiration was dry. MRI was negative for osteomyelitis, so we proceeded with the reconstruction in 2016. There was an intraoperative femur fracture requiring plate fixation, but otherwise had no obvious postoperative complications. Intraoperative tissue samples, unfortunately, however, grew multi-drug resistant Pseudomonas. And unfortunately, also, these results are not reported to myself or ID. 4 months postoperatively, he presented with symptoms consistent with acute PJI and underwent a DARE procedure with intraoperative tissue, again consistent with MDR Pseudomonas. He did well, but presented approximately 3 years later with a draining sinus and progressive pain in his thigh. So although not impossible, the morbidity of a two-stage procedure in this case is clearly very high, likely requiring plate removal, ETO, stem resection, etc. So the decision was to proceed with a repeat DARE. He had 6 weeks of IV antibiotics, and given no oral option is available, he has not remained on further antibiotic treatment. Currently, he has no pain in his hip, his sinus is healed, and he walks with crutches. So again, is this going to be a definitive solution for him? Hard to say, maybe very well a ticking time bomb. For now, I think this qualifies as marginal success. Given the complexity of this problem, he also strikes me as someone who, unfortunately, if they require an explantation, may be unlikely to undergo reimplantation. So what about the prolonged antibiotics after reimplantation? So in this context, as most commonly described, 3 months of antibiotic status post-reimplantation. So the infection and biofilm presumably have been extricated with the implant. Why is there value in this strategy? So to review the points that make this topic important. Number one, the success rates for reimplantation range from 16 to 90%, which means, of course, that failure rates are as high as 40%. Number two, the metrics to determine timing for implantation are imprecise. The literature, as Kurtis described, is replete with studies to determine the diagnosis for infection. What is considerably less clear is determining after explantation whether infection has been successfully treated. Number three, infecting organisms are frequently novel, so it's possible that a large percentage of responsible organisms are not identified at the time of explantation. And lastly, outcomes for a failed two-stage exchange are dismal at less than 50%. So a tremendous impetus exists for aggressive and appropriate treatment. So what does ICM recommend with respect to the role of prolonged antibiotics after reimplantation? So resounding possibly based on the existing literature. The literature has expanded somewhat since this meeting. The study from 2020 from the Knee Society Research Group was a randomized, multi-centered trial evaluating 3 months of microorganism-directed antibiotics after reimplantation for a two-stage hip or knee revision. 185 patients were enrolled from 7 centers. 93 patients received 3 months of microorganism-directed antibiotics after reimplantation. 88 received no antibiotics. 142 patients were available for analysis at a mean 3.5-year follow-up. 12.5% of those patients who received antibiotics failed due to further infection. Almost 30% of those who did not receive antibiotics failed due to further infection. So certainly an impressive clinical impact. About 7% of patients in the treatment group experienced adverse effects related to the administered antibiotics, severe enough to warrant discontinuation. And interestingly, most failures in both treatment and control groups were caused by new microorganisms. So this is a 70-year-old patient with a complex medical history, most relevant for rectal carcinoma and radiation and subsequent pelvic osteonecrosis. She had a pathological femoral neck fracture, multiply failed total hip arthroplasties, and eventually was referred to me with a failed cup cage construct and persistent discontinuity. I revised her to a jumbo cup, which seemed stable at the time, but unfortunately loosened within a short time window. She was subsequently revised to this construct, which is a revision trabecular metal cup cemented to a buttress augment with a modular cup cemented within the implant. She did well for about 6 months, but presented what was thought to be an acute PJI, identified on aspiration as enterococcus. She underwent a DARE procedure, but unfortunately presented a few months later with worsening pain, evidence of component loosening, and confirmation of a persistent enterococcal infection. She then underwent explantation and was revised to a cemented mobile spacer. Reaspiration appeared reassuring for eradication of infection, and she underwent reimplantation with a custom tri-flange. Multiple intraoperative tissue samples, unfortunately, grew C. acnes. So she's currently on amoxicillin, approximately 7 months post-op, ambulating now short distances with a walker. The tentative plan, at least, is lifelong suppression. So obviously this also still represents short-term outcomes, so it's hard to know if we're out of the woods yet. If she were to have a recurrent infection after this, however, as heroic as one could be, I think there would be few options other than a girdle stone procedure. And lastly, what about treatment with suppressive antibiotics for patients with known chronic PJI as opposed to surgery? Is there a role for this? The ICM group in 2018 identified no papers in the literature which evaluated this question, but suggested it could be considered in those patients who could not tolerate surgery or to whom surgery would be unlikely to improve their pain or function. There has subsequently been one paper that I could identify addressing this question out of Spain, published in 2021. 62 out of 72 identified patients were treated with chronic antibiotic suppression. They identified that implant retention was similar in both groups at approximately 80%. Patients on antibiotics had a statistically higher resolution of pain, although almost 30% of those patients experienced some side effects. Despite implant retention, nearly half of those patients had evidence of prosthetic loosening. So ultimately, it's hard to draw meaningful conclusions from this study, but it appears there may be some role for with respect to reduction of pain in patients with chronic infections, but it may not prevent future complications. So finally, a case in point of an 80-year-old female with multiple medical comorbidities who had a remote history of total knee arthroplasty and revision in outside hospital. I had performed a DARE procedure on her in 2018 after a presumed acute PJI after admission with bacteremia. She had remained on chronic suppression and had been lost to follow up to my clinic, although she continued to follow up with infectious disease. She presented in Northwest Hospital last fall with reports of a draining sinus in her right knee, although her pain had remained largely unchanged. She had been in a wheelchair for the predominance of last year and had been actively treated for lung cancer. Repeat x-rays of her knee demonstrated catastrophic failure with migration of the tibial stem from the intermedullary canal. Cultures of her sinus demonstrated mixed cutaneous flora, including MRSA. So a long conversation was had with this patient regarding treatment options, but this also strikes me as a person who would have a very high likelihood of failing a very complex two-stage exchange or likely not undergoing reimplantation. So if surgery was indicated for this patient, I think the most likely definitive option would be an above-knee amputation. At this point, however, her focus is on her cancer care. She has a working foot and minimal pain, so she has elected also to continue with suppressive antibiotics. Interestingly, as we were wrapping up our conversation, she mentioned to me in passing that her hip was doing well. I said, "That's great. Did you have it replaced?" She said, "Yes," and apparently that I had done so in 2016. So I usually have a pretty good memory for these things, but unfortunately, I may have one more thing to potentially worry about. So in summary, I would say that combined surgical and medical management remains the cornerstone for treatment after PJI, after hip and knee arthroplasty. The evidence to guide treatment remains limited, but some recent literature suggests that there may be benefit of prolonged antibiotics in some high-risk scenarios. I think we have to remain good antibiotic stewards, however, and future research is necessary to better refine these indications. Treatment remains for patients a high-risk, high-word analysis. I'll also leave you with this quote from Nassim Taleb, who's an author and risk analyst, who says that preoccupation with efficacy is the main obstacle to a poetic, elegant, robust, and heroic life. So although I think we should practice evidence-based medicine, I think we shouldn't always become fixated with risks and focus purely on statistics. And I also think trusting your judgment and experience will allow you to help people, perhaps despite the odds. Thank you.
Do you like me to go ahead next? And how much time do you want me to try and shoot for?
We have about another almost 20 minutes, Dr. Ehni. Maybe
Okay.
you could leave 5 minutes for questions.
Sure. Let me make sure that this shares appropriately here. How's that?
Yep, we
Showing up
can
well.
see it.
Is that good?
Yep.
Okay. Dr. Fernando's talk was great. It definitely overlapped some of mine, so I'm going to try and skip some of the parts where there's overlap. I was just going to start out with sort of standard initial PJI treatment recommendations from the ID Society of America. They include for just an initial total hip arthroplasty or knee arthroplasty, the preoperative cefazolin, or if they have a positive MRSA screen or a beta-lactam allergy, vancomycin. Not vancomycin and cefazolin, but just vancomycin. And then the pre-op and 24 hours post-op treatment. Initial DAIR recommendations for staphylococcal infections. It's an anti-staphylococcal antibiotic plus rifampin for 6 weeks. Then 6 weeks of oral treatment with anti-staphylococcal antibiotic and rifampin for total hip arthroplasty, and 20 weeks for total knee. And then for other infections besides staphylococcal, the recommendations had been antibiotics plus minus rifampin for 6 weeks. And then a 2-stage procedure, generally 6 weeks had been recommended. So that's been what we had been dealing with in the 2010s. This article was alluded to in the previous talk by Inathobula with extended antibiotic prophylaxis orally in high-risk patients getting primary total hip or knee arthroplasty. And they defined high risk with these risk factors, including increased BMI, diabetes, smoker, kidney disease, autoimmune disease, staph carrier. And they received 7 days of cefadroxil, or in the case of allergies, clindamycin or Bactrim, or if they had a positive MRSA screen, they would use these. And we, by the way, don't have cefadroxil as a formulary agent, so cephalexin is what's used here. They had a large number of patients, and they looked for PJI within 90 days and had 3 groups: those that did not have risk factors, those that had a risk factor, 1 or more, and got antibiotics for 7 days, those with a risk factor and no antibiotics. And it was a good number of patients they had. About 60% did have a risk factor, 1 or more, and about a third got the antibiotic prophylaxis. 90-day infection rate of 1.5% total, with no risk factors, a little lower, 1.1%, with risk factors and no antibiotics, 3%, with risk factors and antibiotics, 0.6%. So the antibiotics did seem to decrease the 90-day infection rate. By the way, for Northwest Hospital, at least back in 2018, I couldn't get any newer data, our infection rate was 2.6%. And theirs was 1.5. So it's similar range for infection rate. There was then a follow-up article by another author, Meneghini, who actually took that from 2,200 patients to 4,200, and they followed up for a year. Their results were very similar, still saw that the antibiotic group did have lower infection rate than the group that did not get antibiotics in high-risk patients, not low-risk patients. They did do a subgroup analysis. Don't know what to make of the fact that in total knee replacements, women had a much lower infection rate than men, and there was no effect for antibiotic prophylaxis in that group. Maybe a numbers thing, but that did come out. They also found a significant correlation in hip arthroplasties with increased weight. The infection rate increased 1.8 times for every 10 kilograms per meter squared increment in body mass. So a big risk factor for infection in total hips. And so it did seem like the 7-day course of antibiotics did decrease PJI rates in primary joint replacement if you had 1 or more risk factors, maybe not in women having total knee arthroplasties. Cephalexin would be the antibiotic we would use here. If they had a serious allergy to a cephalosporin, then clindamycin or Bactrim could be used. And if they had pre-op MRSA, then Bactrim would be better than clindamycin. And of course, a number of things could be done to try and decrease risk, especially weight in total hip arthroplasties. Apparently, if they can lose weight, that's going to help them quite a bit. And that again is the risk factors. Was not shown that this antibiotic helped in people with other medical conditions. The second study that was alluded to was giving oral antibiotics after 2-stage revisions to try and decrease risk of subsequent infection by Yang. And this was just for 2-stage procedures for PJI. Logic was that there were high failure rates, and that in some previous studies, there had been suggestions antibiotic treatment prolonged after procedure may decrease infection. This study was a carry-on of a previous smaller study by Frank that had shown some promising results, decreasing the infection rate. So this was done at 7 institutions, all total hip and knee arthroplasty patients. Follow-up was 24 months, which was very good. they ended up with 133 patients to analyze at the end. They were hoping for 154, but they were just a little short. They did lose 9 patients who had to stop antibiotics because of poor adherence, and 6 of those 9 were taking doxycycline. So that indicates that doxycycline may be a little hard for some people to take on a long-term basis. The group that got oral antibiotics had 13% infection rate, group with no antibiotics, 29%. So that was significant. And Kaplan-Meier curves also showed the oral antibiotic group had less infection, more infection-free percentage than the non-antibiotic group. It turned out that 13 of the 29 failures were in the first 90 days when they got antibiotics. 11 of those were in the non-antibiotic group. So only 2 antibiotic group patients failed in the first 90 days. But after 90 days, there were 16 failures and they were evenly distributed. So the antibiotics only seemed to help while they were being given. And then of the 29 failures, only 6 were with the organism that was originally present prior to the 2-stage procedure. 23 were with a different organism. So this suggested that most infections are with a new organism and that the oral antibiotics only seem to be protective while they're being given. So these appear to be new infections patients are getting, not relapse of their previous infection. So the questions are, first, why were there such high infection rates? There were 29% infection rate in the first 90 days, and they averaged 5% per year infection rate subsequently. So pretty high infection rates. We don't know if this tapers off over time or not, because it only went out to about 2.5 years. Were these very complex patients with poor wound healing, hematomas, seromas, reoperation rates? Is that why they had such high infection rates? Are these data, can they be extended to patients to centers with lower infection rates? We don't really know what our infection rates are for 2-stage procedures. At least I've not seen that data. So it'd be interesting to know, are we up in their range with very complex patients, or are we at a lower range? And then if our data are like theirs, should we prophylax? Should we use a broader spectrum antibiotics since most infections are with a new organism, rather than just tailoring the antibiotics to the initial organism that the patient was infected with, which we don't usually see coming back? Would longer infection be beneficial since the antibiotics only helped while they were being given? Lots of questions from this study that I don't know that we know the answer for yet. It does seem reasonable, though, to consider using a 3-month postoperative antibiotic prophylaxis for patients who are felt to be at high risk for postoperative complications, maybe in that 30% range. Patients who seem to be much more simple, I'm not sure that this is an advantageous technique. Like for an example, I've worked with a community orthopedic surgeon who does do 2-stage procedures, but his patients are not complicated patients. They're all very straightforward, low risk of postoperative complications. We have never had a failure in his patients, despite never giving post reimplant antibiotics. And then the last study that was also mentioned somewhat was the 6 versus 12 weeks for prosthetic joint infection. And this was primary outcome was in persistent infection within 2 years after completion of antibiotics. They compared 6 to 12 weeks post-procedure, both knee and hips. The results were that 41% of their patients had DAIR, 37% 1-stage, which we don't do very often, 22% with 2-stage. Median duration of IV antibiotics, only 9 days. This was a French study. Then oral was 33 versus 75 days. Compliance was pretty good, 6 versus 12 weeks. Mostly they used rifampin and a quinolone in combination, so a little different than what we do here. Kind of standard bacteria we're seeing. As mentioned in the previous talk, there was persistent infection in 18% at the 6-week treatment, 9% at the 12-week. So persistent means the same organism that you had in the initial infection. They did subgroup analyses, which favored 12-week treatment. However, the only statistically significant findings, not favored, but statistically significant, were DAIR, had an improved outcome with 12-week treatment, and first episode of PJI did better with 12-week treatment. Subsequent ones did not. Now, there were also treatment failures due to new infections, but that was equally distributed between 6-week treatment and 12. So new infection rate was not really affected by this 6 versus 12-week treatment. Also, probable treatment failures where clinically it seemed like a failure, but they couldn't get an organism, no difference between 6 and 12 weeks. There were some increased minor side effects in the 12-week group, but no serious ones. So it looked like the 12-week treatment versus 6 weeks was superior in preventing PJI with persisting infection, was not superior in preventing infection with new organisms, and also not more effective in organisms having culture negative relapses with no organisms. These patients also had pretty high infection rates. If you took documented and suspected infection rate, it was 26%. So these were probably also complex patients with a lot of comorbidities, poor healing, et cetera. And the most significant effect was in the DAIRs and initial PJIs. And the difference from our center and theirs is that their treatment was mostly oral, and they had a lot of one-stage procedures, and also had a pretty high infection rate. And again, I'm not sure what our infection rate is to compare that to. So if we look at how we could use this information, perhaps for the staff PJIs, we're already treating them at least 12 weeks. So they're all getting 3 months treatment anyway, so not much different there. But DAIRs with other organisms, recommendations have been 6 weeks. So we may consider 12 weeks in DAIRs with other organisms. That would seem reasonable. And then for 2-stage patients, maybe consider extension to 12 weeks if they're not having optimal progress. Their inflammatory markers haven't normalized. They didn't have good wound healing, rapid clinical improvement prior to 6 weeks of treatment. That might be a group where 12 weeks would make more sense. If we compare this last paper, the Bernard paper, with the previous one, the Yang paper was only 2-stage revisions. And interestingly, most of the infections were new infections. So that suggests that 2-stage revisions are pretty effective at clearing the original organism, but they do tend to get new infections if they're complex patients with, poor healing, et cetera. In this more current paper we just talked about, the Bernard paper, most of the infections were persistent infections, and they were mostly in the DAIR patients, suggesting that DAIRs are less effective at clearing the original organism than 2-stage revision. So I think that's why the results are different. Both papers had pretty high infection rates, 26% in 2 years in one and 29% in 6 months in the other, suggesting these were probably very complex patients. Not sure how those compare to our patients, although we certainly have some very complex patients. So going back to the original treatments, some thoughts from these papers are definitely to consider cephalexin 7-day post-op, post-discharge in high-risk groups for initial total hip arthroplasty and knee arthroplasty, not in the low-risk patients, did not benefit them. For DAIRs, would not really change what we do for staphylococcal infections, but would definitely consider 12-week treatment in some of the other infections with organisms that are not staph. And then 2-stage procedures, consider 12-week treatment in certain cases that are not responding as well after 6 weeks as you would hope, and consider the 3-month post-implant antibiotics in high-risk patients where we might estimate a risk of poor healing or complications in the 30% range. Not a real straightforward patient, but those patients. And as Dr. Fernando said, there's also a thought of chronic antibiotics in patients where you're really concerned they're not doing well in either the DAIR or 2-stage procedure group. I didn't address that because the data is so limited, as he pointed out.
Dr. Ehni, is that your last slide?
that is my last slide. I'll stop sharing there.
Okay, thank you. That was really a fantastic presentation for a really complex topic. We're running a little late for questions, but if anybody has any, you can just speak up or raise your virtual hand. I'll start out with one comment going back to something Dr. Fernando was discussing earlier in the talk, and that's that some of the data that has led to a push to shorten the duration of antibiotics have come from studies that were not specifically in total joint patients. And it reminds me of about 25 years ago when I felt like orthopedics was almost invaded by vascular surgeons and pulmonologists and hematologists, really pushing us to be much more aggressive using DVT and PE prophylaxis in total joint patients based on studies that were not done in total joint patients. And we all had a lot of concerns about the complications we would see in patients getting that more aggressive treatment. And now we're back to doing what many of us were doing at that time, which is using aspirin for prophylaxis. So I do think we have to be careful. I had one question for Dr. Ehni. In primary total joint replacements, at least for hips and knees, the reported incidence of gram-negative infections is not insignificant. It's low, but in some studies, it's, I think, as low as 2 or 3%, but other studies as high as 10%. And so what's the rationale for prophylaxing our beta-lactam allergic patients with just vancomycin, or our patients that have MRSA on screening nasal swabs?
Well, I don't know that anybody's looked at just gram-positive versus adding gram-negative coverage in that situation. By far, the most common postoperative infections are gram-positive. Yeah. And if you're really worried about gram-negatives, the cefazolin isn't a particularly robust gram-negative agent. 30% of E. coli are resistant, and a high percentage of a lot of the other common gram-negatives are resistant. So it's not what we use if we're worried about gram-negative organisms like in intra-abdominal infections. We don't use it there. So I think you either really worry about the gram-negatives, but then you have to give much more broad spectrum coverage with a lot more side effects, or you focus mostly on the gram-positives with the vancomycin. And if we had strong evidence that treating the gram-negatives made a difference, we probably should, but I'm just not aware that that data exists.
There's a question from Dr. Greenwald, and I'll just read it in the chat box. Has the work by Stephen Cates been reviewed for this talk? His electron microscopy studies show that within 48 hours, staph enters bone caniculi, basically setting up shop there. It would presumably be impossible to eradicate the infection without surgical resection and retaining implants. Is there a role for immune therapy rather than antibiotic therapy for PJI? So far, staph vaccination is not a successful option. Alan, if you're still here, do you want to speak up and make sure I got that right?
Yeah, that's what I was asking. If you listen to what Steve Cates says from Virginia, that it would be impossible to retain your prosthesis with and successfully treat the infection. The bacteria just don't go away. They stay, they live. And maybe there's a novel approach to this with some immune therapy, because antibiotics obviously don't cure the infection 100% of cases, whether you retain or whether you do two-stage, whether you keep antibiotics going for months and months and months or not. I'm wondering if antibiotics are ultimately going to be replaced by something else.
Well, I don't know about immune therapy, but I do know that there's a lot of research looking at surface coatings for prostheses, for example, that would leach out, silver ions over a long period of time, which might address something like that. Are any of you familiar with any immunotherapy?
I would just interject, Howard, that I know there's some active research into immune therapy, particularly with fighting invasion of bone canaliculi and kind of early osteomyelitis, but I don't know of any that's clinically ready.
Are there any other questions? Okay. Doctors Ehni, Fernando, and Carlock, thank you. That was really a wonderful presentation, again, of a really complex topic, something that we should probably update with another grand rounds in 2 or 3 years. Thank you, everybody. Have a great day.
Thank you, everybody.